the first instance, it remains to be determined how penetrant carrying these sorts of genetic variations is. If carriage of these gene variants increases your risk of sarcoma, but it's still a very low risk, then it's probably something that sheds light on cancer biology rather than translating immediately into risk prevention strategy. On the other hand, the reality is that currently we know a lot about cancer biology and there are cancer genetics, and there are quite a few well-accepted mechanisms for modifying that risk in breast cancer and bowel cancer and ovarian cancer and so forth. So we do find some individuals in our cohort who carry genetic variation outside of what I've just described in relatively well-described and well-managed cancer genes. And for those people, the important clinical result, of course, is that about 1 in 12 people carry some variation in those well-described pathways. And for them, of course, that does translate into potentially immediate benefit. I'd like to see a greater degree of genetic literacy or awareness in the sarcoma clinical community so that we can get the sort of relationships between the cancer genetics groups and the oncology groups that we see in breast cancer, where cancer genetics is intimately integrated into clinical care. The other side of things is that these new pathways may lead to perhaps synthetic lethal strategies that are comparable to the sort of strategies that are used in people with mutations in BRCA1 and BRCA2, where PARP inhibitors are used. It's possible that having a defect in telomere function or centromere function may mean that sarcoma patients who carry those sorts of functional defects may be more sensitive to certain types of treatment or novel therapies. And I think we don't understand really very much about that, but that's an important area of research. The final bit that we're doing more or less now is to create this comprehensive map of genetic variation associated with sarcomas. And so what are we missing? Our study has done a reasonable job of looking at rare genetic variants that we thought might be highly penetrant that are associated with sarcoma risk. But we haven't studied common variants, and we're beginning now to look at genome-wide association study techniques, because the whole genome contains all the common and rare variants. We can count them all. And so what we want to do is count those variants and see what they contribute to sarcoma risk. That's important because there are beginning to be strategies to give people polygenic risk scores, and polygenic risk scores can be used to identify those who are at individual risk in the same way that rare variants are. So that's a potentially important clinical group as well for the future, as well as filling in some of the gaps in the biological pathways that may be specific for mesenchymal cancers. And then, of course, there's a whole type of genetic variation which is relatively poorly understood in the clinical sense, like structural variants, not just single nucleotide variants, indels, small-scale variants, but actually shifting of whole regions of the genome around, which I think is quite important for biology. Meiotic recombination is a well-described mechanism by which humans vary their genomes just and create genetic diversity in normal populations. So there may be reasons to expect that mapping structural variants may identify still more individuals who carry changes that we can't measure at the moment that might contribute in the same way to risk as those who carry these classic SNVs and indels.